Endotracheal intubation is a life-saving but dangerous procedure. Whenever possible, optimize your environment and mechanics for first-pass intubation success. You've decided to intubate your patient. Let's presume there's no trauma and the patient is spontaneously breathing. In preparation for intubation, first place oxygen on the patient by nasal cannula at 15 liters per minute. This technique extends the safe apnea time during intubation due to the higher concentration of oxygen in the natural reservoir of the pharynx and trachea, which diffuses into the alveoli. This method of oxygenation will continue until the patient is intubated. Then, place the patient on a 100% non-rebreather mask. If the patient condition allows, keeping the mask on for 6 minutes completely washes out the nitrogen in the lungs and replaces it with oxygen. This process is called pre-oxygenation or nitrogen washout. If there is concern for airway obstruction from the tongue, an oropharyngeal airway should be placed immediately. A nasopharyngeal airway will also assist in keeping the airway patent and is relatively tolerable if a patient begins to wake up. Determine the correct size of the oropharyngeal airway by placing the ends of the airway between the lips and the earlobe, or a lip-to-lobe measurement. Determine the correct size of the nasopharyngeal airway by placing the ends of the airway between the nares and the earlobe, or nose-to-lobe measurement. One of the important components is correct positioning of the patient, especially to align all the axes of the airway in almost a straight line. If you'll notice here that the ear to sternal notch, here is the ear and the sternal notch is here, we want to get those parallel to the ceiling. And so the head needs to be ramped up in order to do that. And also the facial plane, you notice that the facial plane is also at an angle. We also want that facial plane to be parallel to the floor or to the ceiling. In order to do that, we can use blankets or pillows in order to correctly ramp up the head to create that positioning. So if you'll notice here, you'll see that the ear to sternal notch structure is now parallel to the ceiling, and the face plane is also relatively parallel to the ceiling. This is a good position for the patient to be in to align all the airway axes for optimal visualization of the glottic opening. Another thing that's important to recognize is that the best working space is for the face, the plane of the face, to be between the xiphoid process and the umbilicus of the operator. So in this case, the plane of focus is just, here's my xiphoid, here's my umbilicus. So this is a really good or optimal working space, a working height for endotracheal intubation. The diagram on the left demonstrates optimal alignment of the airway axes for endotracheal intubation. These diagrams emphasize the ear to sternal notch plane and the facial plane parallel to the ceiling as clues to optimal airway axes alignment. Optimal handling of the laryngoscope during progressive visualization is to hold with the thumb, index, and long fingers. This gives you the best tactile sensitivity as you advance the laryngoscope towards the glottis. Do not place the blade fully into the mouth and slowly pull back. This technique could lead to esophageal intubation or injury. Keeping your elbow tight to your thorax during laryngoscopy decreases effort and allows you to maintain glottic visualization longer if needed. The clean hand technique can be used to open the mouth to begin laryngoscopy, and it is the preferred method of mouth opening. When we place an endotracheal tube, another option for guidance, especially this tube which is so flexible that it would be nearly impossible to try to pass this tube without any structure, is we use what's called a malleable aluminum stick called a stylet. We'll place the stylet to the end of the endotracheal tube, and then we'll go ahead and make it approximately that size. And then what we're going to do is we're going to shape it in what was called a straight to cuff position. And at that point, we're going to go ahead and bend this to about 30 degrees. And it has sort of a hockey stick sort of shape. And that is the tube that's ideal for the passage of an endotracheal tube using a stylet. Okay, so we're going to go ahead and do the clean mouth opening technique. I'm going to go ahead and introduce the blade to the right side of the mouth, and then again do the similar progressive visualization. We see the uvula, posterior pharynx, slow scooping motions. We're going to see the epiglottis there. And now we'll hopefully get our tip into the vallecula. Again, small scooping motions. I think we're now close to the vallecula. A little bit further. I'm actually over on top of the vallecula. And now we can kind of see it. There we go. You can kind of see how that pops in. Now we're taking our tube with the hockey stick configuration. We're going to go ahead and enter the right corner of the tube again. And we're actually going to head down and then down to the posterior aspect of the oropharynx. And as we spoke before, we want to be able to keep the glottic opening in vision as long as possible. That's why going down and coming up is the best idea. So now we're coming back up through the cords. Now I'll have an assistant go ahead and remove the stylet at this point, while I maintain control of the endotracheal tube. We'll blow up the balloon, and then we will confirm tube placement with bag valve mask, end-tidal CO2 detector, and listening to the lungs. Okay. The balloon's been inflated. Now we're going to go ahead and put the end-tidal CO2 detector and bag valve mask onto the ET tube. We want to, sometimes it's best to preload the end-tidal CO2 detector on the bag just so you don't lose it. Once we've done that, we'll go ahead and securely place that. And then we'll go ahead and ensure, and it looks like we have good air movement. At this time, an assistant would also listen visually, and we'll notice that the end-tidal CO2 detector, it has color change. Let's just go with it. So we try to use multiple methods to confirm endotracheal tube placement. So we're going to be using the clean finger open mouth technique. I'm going to go ahead and take the handle and blade. I'm going to hold it with 3 fingers, or really with these 3 fingers, because what I want to do is going to be predominantly a feel. I'm going to go ahead and introduce the blade into the right side of the patient's mouth and slowly sweep the tongue from right to left. At this point, I'm going to slowly scoop in small scooping manners, where I'm going to hopefully, I see the epiglottis, okay, I see the vallecula. At this point, I see the intra-arytenoid notch, and I see the glottic opening. At this point, I would ask for the bougie, and I would go ahead and place the bougie. At this point, I actually can feel the tracheal rings as I pass the bougie. At this point, I would also ask for the endotracheal tube that I've already checked to make sure that the balloon is functioning. I'll go ahead and place this. Okay, when I'm about 23 centimeters at the teeth, I'll go ahead and remove the bougie. I can blow up the balloon. Ideally, what I'd like to do then is go ahead and, using an end-tidal CO2 detector and bag valve mask, I'll go ahead and bag the patient, and I'll have an assistant or a colleague go ahead and verify with breath sounds as well as end-tidal CO2 detector. Only when breath sounds have been verified will I remove my laryngoscope, and now I will go ahead and secure the tube. And that's what I expect you to do. For this educational activity, we will divide into 6 groups of 4 students with 1 facilitator. Each student will do 1 stylet intubation and 1 bougie-assisted intubation. Rotate so each student does every position. Reset equipment every other intubation.